postures.
Thank you. Thank you, Dr. Biswas. My topic is very straightforward. Which patient and when should you refer to a uveitis specialist? This is mainly for the comprehensive ophthalmologist, and it starts with the clinical scenarios. The first is that I look at the patient and I do understand that what I'm looking at is potentially devastating disease, which needs very aggressive management as well as the close monitoring of the complications. So I think this would be the first scenario when I would consult a uveitis specialist, because if I do not, right from the beginning, it might result in a lot of complications and ocular morbidity. This is one such example. This is acute retinal necrosis. And these days we are seeing the acute retinal necrosis, which is post-COVID very fulminant, and it's behaving a bit differently with high viral load. So it's better to get it to a higher center right in the beginning rather than trying some antiviral and then ending up with the complications. The second is I look at the patient and somehow my sixth sense tells me, or my clinical acumen tells me, that it could be a lymphoma, it could be malignancy, or it could be metastasis. This is one such example. You see a patient coming with these deposits, these are, you will find something is deposited in the subretinal space. It's neither retinitis nor choroiditis. Or you may have these small orangish nodules and they look something different. I do not know what it is, but I think it could be lymphoma. It is best to refer this patient at this point of time and not to start on steroids, because the problem is patient will respond to steroids, but when ultimately the biopsy is done, it will come out to be negative. So the diagnosis of lymphoma will be delayed. So if suspected, please refer it at this point. The third is I just look at the patient and I do not know what it is. And believe me, it happens. At least it happens with me. I look at it, I said, I don't know what it is. But if you are not in a uveitis setting and you don't have a paraphernalia to figure out what it is best to send that patient to someone who could. For example, this young boy. I'm not going into the details, but this is what you see in SSPE, the patient who has not received measles vaccines. These are not the cases you will see every day, but if you see something which you just don't understand, please do not start empirical or presumptive therapy. Because we do situations like this where people say Monteus is positive. What will Monteus do? Monteus is not even required. So don't go off the track and just, say that I don't know, I need to refer the patient. The fourth is patient is under my care, but patient is not responding to the treatment the way I anticipated. For example, this is the patient. On top, it shows it's a TB serpiginous like choroiditis. Fine. I started the patient on treatment, and the bottom picture shows that while on ATT and some steroids, the patient is worsening. There are new lesions appearing. So there are a lot of questions in my mind at this point of time. Should I stop ATT? Should I reinvestigate the patient? Should I increase steroids? Should I stop steroids? These are multiple questions a comprehensive ophthalmologist would have. So this is just to show the course of the disease. We have tried so many things, but my point here is if the patient is worsening on therapy, please refer it to a uveitis expert who can figure it out what to do. The fifth is patient is having multiple recurrences every time I reduce steroids, and from where I am, I see a lot of referral, and I do see the hesitation on part of comprehensive ophthalmologists to give high-dose steroids and to give it for a longer time. So what happens typically? The first day you see the patient, you write 50 milligram for 1 week, 40 for 1 week, 20 for 1 week, and done with it. That is very bad actually for uveitis because it tends to keep coming back again and again. So if ever I am in a situation like this, or I have a patient who is in a condition where I anticipate will need a long-term immunosuppression, even if you have not referred the patient initially, but if you think patient is having recurrences, needs immunosuppressive, please refer it at that point of time. And a typical example is VKH and sympathetic ophthalmia. There is no way a patient of VKH will be free of recurrences with steroids alone. They will respond, you will get good results, but they will keep coming back again and again. And every time there is a recurrence, there is a residual morbidity in the eye. So please refer them at the first go, if not at the time of recurrences. Sixth, this patient is not having a typical phenotype and I'm confused what I'm dealing with. For example, this is the patient who has few vitreous cells and has like this. So I do see patients referred as retinitis pigmentosa with vitritis. There's nothing like that. The patients with dystrophies and degenerations are going to have few vitreous cells. So if you are confused, if you think there is an intermediate uveitis happening in the backdrop of dystrophy, please refer this patient to a higher center because this is the patient with CRB1 mutation that was being treated as uveitis. Seventh is I am unable to make up my mind whether it is uveitis or endogenous endophthalmitis. And that can cost very heavily to the patient because the treatment are very, very different. For example, this patient, somebody was managing it as retinitis and it was actually, he had silicone oil in his eye. And I don't know how somebody made the diagnosis of reactivation of acute retinal necrosis in a silicone-filled eye. And this was actually a fungal endophthalmitis, an abscess arising from the scleral buccal which kept on growing under this, and that is the calcofleur showing the fungus. Pediatric uveitis, don't ever, it's very tough even for the uveitis experts. So never ever, treat children if you do not have the paraphernalia. Please refer, please do not start them on steroids. We do have very good drugs, biologics and all, which should be given initially. For example, this looks like, one more minute, Dr. Biswas.
Yes, sure.
This looks like anterior uveitis in a child, but actually it's a case of TINU, and then we have Blau, and we have lots of things which need very aggressive therapy. So please do not just think that children have a very minimal anterior uveitis and you can
treat because that's a very different ballgame altogether. Or they could have masquerades, for example, a hypopyon in a child. It's never due to inflammation. It's mostly due to masquerades which include leukemias
and sometimes retinoblastomas. Geriatric uveitis. Masquerades need to be ruled out. If a person of 70 years comes to you with the uveitis for the first time in the eye, don't ever think about it, just refer to the higher center because autoimmune disease does not come for the first time at the age of late 60s or 70s. Example is this lady, some vitritis and autofluorescence shows this leopard skin, it is actually lymphoma. And last, if you plan to do cataract surgery in a uveitis patient who looks quiet to you today, you may have seen the patient for the first time at this point, and we all love doing surgeries, and as a surgeon, we just want to shift them to OR and put an implant. But you have to resist that urge or the itch. It's important to involve your uveitis expert for the good evaluation and make this eye quiet under his supervision for the next 3 to 6 months. And this is how you should refer. So to conclude, please refer whenever you are not too sure of the things, because there is no ego involved in referring. Thank you very much, Dr. Viswas.
Thank you.